Thank you again, and would like to follow with the next lecture after this great discussion by Dr. Faqih, who, if anything, set up the stage for more of details about checkpoint inhibitors. And this time I'm going to be talking about the checkpoint inhibitors as well as, of course, targeted therapies in regard to HCC. And these are my disclosures. And these are my contacts. And of course, please feel free to reach at any time and make sure you follow on the Twitter. So if anything about HCC, this is the right handle to follow. And of course, we start the story with the news that has been really very impactful. And we heard about it almost a year ago. It was presented at ESMO Asia back in December last year. The ImBrave 150 looking at Atezolizumab plus Bevacizumab, and was compared to the standard of care Sorafenib. As we can see here, there is clearly a major advantage in regard to survival for the Atezolizumab plus Bevacizumab, with the median not reached even by the time it was reported, while Sorafenib 13.2. Of course, please note that, as you can see at the x-axis, even at the time of reporting, there's only 3 patients left on the Atezolizumab plus Bevacizumab, where presumably, in other words, it's going to be somewhere in the range of the 20-plus month. The progression-free survival, again, was also positive. And if anything, we can see here that it was 6.8 months for the Atezolizumab plus Bevacizumab and 4.3 months for the Sorafenib. I know there has been some of us who brought up the question, would have expected more. But to be fair, we really are unable to really how much this kind of combination brought up in regard to the whole story of the different therapies that are available. But what is the contribution in regard to the different therapies that are available? By all means, it is impactful, as we have seen with the survival data. Interestingly, the outcome, and this is very important for all of us, has been noted to be positive independent of age. This is one variable that we take sometimes into perspective among many others. And we can see here clearly that Atezolizumab plus Bevacizumab did favor an outcome that majorly was improved compared to Sorafenib, independent of age. One story, though, that come into play is anti-drug antibody that, as we can see over here from work that was presented back in February this year in CCR, it shows clearly that contrary to all other checkpoint inhibitors, Atezolizumab can induce a potential 50% chance of anti-drug antibody among patients getting it. While this compares, as you can see, drastically to a very minimal 1 to 2% in Pembrolizumab as an example. What does that mean? It implies that if the patient got the drug, i.e. Atezolizumab, they have a 50-50 chance they will get an antibody to the drug, i.e. the drug will not work. It will be disrupted by the antibody and it will not work. Interestingly, the FDA came to note this, and this was added in the package insert of Atezolizumab for HCC. And we can see clearly here that for the whole study that I just showed you, the hazard ratio was 0.58. It improved markedly for the anti-drug antibody negative, i.e. those patients who did not get anti-drug antibody to 0.39. But on the other hand, for the anti-drug antibody positive patients, in other words, those patients who develop anti-drug antibody to the Atezolizumab, their hazard ratio worsened to 0.93, i.e. almost telling us that Atezolizumab plus Bevacizumab is as good as Sorafenib in that population. How to apply that? Not yet there, but nonetheless, it's something to think of. And of course, we should not really forget about the tyrosine kinase inhibitors that have been really with us for a long while. This is Sorafenib that was compared to the placebo and showed an improvement survival that remained with us for almost 12 years as literally the sole standard of care available for us. Afterwards came Lenvatinib, and Lenvatinib was looked at into a non-inferiority study versus Sorafenib. I know some of us bring up a question as if like it's a shorter track to get on to get a positive study doing a non-inferiority. Not necessarily true, because number one, statistically are totally different between superiority and non-inferiority. And number two, I think I give credit here to the investigators led by Dr. Kudo, is that after all, the racetrack was already defined. This is how much a tyrosine kinase inhibitor can pull, 13 or about 13 months in survival. However, how much can every runner in a track field and in a relay race into that racetrack? That's interesting. If anything, it clearly shows that lenvatinib might have that power, even though it is still within the same defined racetrack, which is the 13 months in survival. What is the power of lenvatinib? If anything, an improvement of PFS, impressively 7.4 months compared to the sorafenib 3.7, almost close to 3 times higher. And also, of course, an improvement in response rate, which actually passed on to about 41% by by modified RECIST, and for about 26% by RECIST 1.1. So where does this leave us with, if you recall, at least a few years ago, we're all talking about Nivolumab and all excited about a anti-PD-1 as being the potential new standard of care for sorafenib. This is actually from the Checkmate 040, a study that we're all very familiar with and we're very much involved in. And it showed, after all, that a certain duration of response is definitely there for Nivolumab, despite the response rate remaining about 15-20%. And that's why I showed the numbers of the lenvatinib a second ago. Nonetheless, this was approved by the FDA specifically for that duration of response, which was rather impressive, even though afterwards, the Checkmate 459 comparing the Nivolumab versus sorafenib in first-line setting was negative. I know, and we hear about maybe statistically it was negative, but clinically positive. I call this negative. This did not work. And interestingly, a few years ago, if we were to even dare saying what if, will be questioned on that. But ultimately, it showed that the checkpoint inhibitors by themselves are not enough to get or pull an increased or improvement in survival. Of note, the same thing happened with Pembrolizumab. Again, as you can see here, duration of response is definitely there. And if anything, however, the comparison to a placebo in second-line setting was again negative. The drug is available in second line based on the data that I showed from the phase 2, but the phase 3 trial was negative again. To take us back to the tyrosine kinase inhibitors, that really seems to kind of, continuously showing the positive outcome. Regorafenib in conditional prior sorafenib exposure got an improved survival versus placebo, as we can see over here, and this is available to all of us. Cabozantinib, again, versus placebo in second and third line after sorafenib as being the only default therapy available at this point in time, again, was positive. Even though I would say you can, of course, use it regardless of what you take first. And interestingly, the cabozantinib, even in patients who are Child-Pugh has shown a certain improvement in outcome, as you can see over here. Maybe not necessarily to the same magnitude, but nonetheless, it's still there. And I please again here show you see that I'm illustrating the different variables that we thought about as being the subgroup analysis based evaluation that we might do, like for example, age, Child-Pugh scoring. I'll come to that discussion a little bit later on. But before that, ramucirumab, anti-VEGF, again versus placebo, showed improved survival in that study, however, that was specifically limited to patients with a baseline alpha-fetoprotein more than 400. I know, and we might look at this in different perspective. The survival was not in the same robust outcome as it was for the other tyrosine kinase inhibitors. Here, only 8.5 months for the ramucirumab versus 7.3 for the placebo. And if you recall, this was kind of brought up from the perspective, is it really a prognostic? Is it a diagnostic? We are not sure. Nonetheless, in that setting, at least we can take it at face value and have this drug available as needed. I go back to the checkpoint inhibitors. And this is a very important model that we all are dependent on because after all, this is where the anti-PD-1, anti-PD-L1 activity happen at the cell membrane level, which we can see in point number 7 on the cycle. And then, of course, you can see the anti-VEGF, which is like around point number 5. And this is really where the ImBrave 150 kind of, bring in their combination effect together. And it's not the only one, though. At one step up in the sequence of events from the lymph node to the cell membrane level, lenvatinib as an anti-FGF plus pembrolizumab PD-1 also showed us some impressive data, including some CRs. How would we explain that? Actually, if anything, it appears to be that anti-FGF, exemplified here by erdafitinib, in combination with anti-PD-1, can, of course, kill cells, i.e. K6-7 will go down, and increase immune activity, increase CD3. And that's probably what could have translated into that improvement in survival, despite, of course, the limited data for the lenvatinib plus pembrolizumab in this phase 1, phase 2 study, which is at 22 months. Of course, we're waiting for the LEAP-002 study that will give us a better delineation about this important combination. This brings in a very important concept, and that's really where I illustrated all those examples to come to the important point. After all, as we all know, degeneracy come into play because the further down into the chain of command, there's a potential for certain degeneracy or different pathways to be taken to kind of, bypass a certain blockade. And that's where anti-VEGF come into play. One step above is anti-FGF, but of course, way up on the top of the chain of command is the anti-CTLA-4. And this is exemplified, if anything, by this important description where CD28 talk to CD8 and 86, kind of invite them to a very robust drink, like some solid coffee that energize them and let them pass the message all the way to cell membrane level. CTLA-4 come into play and convince CD80 and the CD86 to drink with them probably some alcohol that make them fall asleep and they can't cause their effect anymore. And this, if anything, this is where anti-CTLA-4 come into play, take away CTLA-4 and let CD86 do their job as it should be. By the way, this is a good exemplified, simplistic way, at least for me, to explain to others the Nobel Prize that Jim Allison received last year collectively with his colleague from Japan. And this combination, by the way, is already into play. We know very well about Nivolumab plus Ipilimumab, which is exemplified over here with the improvement in outcome. And enough, this is that already approved by the FDA as a combination in the second line. And interestingly, again, to go back to the same story as I'm bringing examples of potential kind of, subgroup potential analyses, we can see here that independent where the patients are from. We spoke about age, we spoke about the liver functionality, and now we're talking about the ethnicity. And we can see that, again, it did not matter. And by the way, this combination has been looked into different drugs, durvalumab plus tremelimumab, which, if anything, it showed that one dose only of the tremelimumab at 300 grams is enough to kind of enhance that effect with a survival rate for up to 19 months. Not only that, but durable response is very evident as well. We can see here in the delineation in the left upper corner, the T300 plus D with the robust answer in regard to some partial responses and duration of response, which of course will await for the Himalaya study looking into the durvalumab plus tremelimumab versus sorafenib, and we're waiting until we see the results of that clinical trial. But what happened there? If anything, the story is such. This is data from almost 20 years ago. Snorri-Thorgerson at the NCI at that time, if anything, helped us delineate that HCC will depend on different variables, among which the etiology. I spoke about others, but here we'll talk about the etiology. And he clearly said that, in other words, the disease is not the same. If you talk about a hepatitis B patient, maybe they have HCC, but it's merely driven by telomere shortening. You take a hepatitis C patient, the HCC is probably driven by the EGFR RAF pathway, i.e. maybe something like sorafenib might work. Alcohol, maybe DNA methylation, morbid obesity and NASH, maybe EGFR, P53, etc., etc. Well, that perspective proved not to be working because, as we all know, the different tyrosine kinase inhibitors and different checkpoint inhibitors were giving them to all patients independent of the etiology or ethnicity. Interestingly, though, we have seen in certain examples, and this is one of them, that, for example, patients who have the cells that are enhanced with T cell activation CD3+, CD8+, Ki67+, are the ones that will fare most from the combination. This is an example for the durvalumab plus tremelimumab, and we can see that the canons of CD4 low and CD8 high, which is exemplified by the purple color T300 plus D. And if you look to the right, you'll see that these are the patients that really benefit the most from the combination of the tremelimumab plus durvalumab, the T300 plus D. And if anything, it really showed the benefit, regardless of what combination, regardless of from single agent, but always showed faithfully for the patient who have CD3, CD8, Ki67 plus T cells. What does that mean? If anything, there are some other regulators coming to play, and this is like novel data that's coming out as we speak. This is rather very new data from nature, that if anything, it shows here the Foxp3 as an important regulator in regard to all the activation of the immune cells activation. With, as we can see here, some negative regulators. The latest addition to those are actually the ring figure protein 20. You can see it next to number 4 on the y-axis, and the ubiquitin-specific peptidase 22, which is on the positive regulator side, which you can see on top of the screen. These regulators are yet to be understood further. Not only those, but also we have also the myeloid response score. And the myeloid response score, as we can see over here, can really range the cells from being very immunocompetent all the way to immunosuppressive. And if anything, this is driven, at least in that example, by the CD169 activation and CD8 activation. And of course, you come into play here, the PD1 and PDL1 as well. These are only to illustrate the point that, after all, maybe a better read on the story is not that table that we have seen that was developed based on the data from Snorri-Thorgerson, but rather it's a broader perspective that looks more like a star looking at CD4, CD8, Foxp3, myeloid cells, CTLA4, Ki67, PD1, PDL1, and literally, as of just this week, also we brought up hepatitis C and hepatitis B as important variables too. Until that day, and we will wait until this data comes out, we will be dependent on further development, and among which I'll only give it as a introduction to CAR T cells as potential future for the therapy. I think this is really where the money is going to go ultimately. And until that point in time, we can say that combination therapies are no doubt novel. Totally agree, they are positive. I think we showed quite a bit of data on that, but remain disruptive. And the combinations that at least we have for now are the anti-VEGF plus checkpoint inhibitors, TKIs plus checkpoint inhibitors, and the dual checkpoint inhibitors. Alterations of approaches, including overcome inhibition and sequencing, are ongoing, and this is an important variable we didn't talk much about. But nonetheless, the most important is the upcoming efforts will focus on really evaluating and knowing in advance who are the responders and non-responders based on this map that I showed you. And of course, the CAR T, just stay tuned. I invite you to definitely look into more details of this at the Hepatocellular Carcinoma Tumor Immune Microenvironment single topic conference that's coming up on December 4 and 5. This is a Apple new event that we are very proud to host from Memorial Sloan Kettering along with the University of Hawaii. And it will be all about tumor immune microenvironment. And we are honored to welcome actually one of the experts in the field, Judd Walshock, who's going to teach us all about the tumor immune microenvironment from the world melanoma and how can we apply it for HCC. I'll stop here. Thank you very much.